I wanted to talk. I'm at the point where I'm running out of like core concepts to kind of bring up, and I just sort of start talking about things that I see in front of me and narrating my life, my medical life. So I wanted to bring up kind of 5 things that I have noticed recently on Airways that I think may make a big difference. And when I brought up to somebody about like, hey, you could do this, it kind of stops occurring to you that like, oh yeah, I haven't told somebody, I have never told this guy that before, and he's never heard it, even though I've said the thing 100 times, and I feel like I'm repeating myself, and surely everybody must know it. There's some stuff that we haven't, relayed before, so I wanted to kind of bring those things up. Pardon me. So this is just what Walt's talking about, what he sees. Number 1, if you are not used to doing a jaw thrust, you should. And we have all heard the head tilt chin lift. Everybody gets kind of taught that in your BLS stuff. Hopefully somebody is showing you the actual jaw thrust itself. Now, what is the jaw thrust? Here is the example. When you actually take the jaw and rock it forward like that. Here he's going to, it should come up here in a second. Here's the actual guy. Notice that he is actually putting his hands behind this gentleman's face and lifting his jaw up. It's not tilting their head back and kind of like, lift the chin with your thumb. It is grab the guy's face and try to pull his jaw off his face. Don't quite do that, but you kind of get the idea. It's not just a little passive thingy that you do. Just make sure right here. Here's the example of it. Again, in pictures that you should see. Back and forth and back and forth. You're literally lifting the jaw up, which gives you better airway access in general. And again, with feeling, there he is. Jaw up. He relaxes again, and the jaw up. It is putting your hands behind the person's mandible and literally lifting it up. Why should you be doing this? Well, number 1, it's going to make your bagging a whole lot easier. We always teach that you're supposed to lift up the guy's jaw, or lift up the guy's face and into the mask, right? You're not supposed to smash the mask down on the guy's face. You're supposed to lift the whole thing up. The way you do that, that's essentially describing the jaw thrust there. You're pulling the whole jaw forward up into the mask itself. Now, you may say like, well, I'm sort of doing that already. If you are not literally grabbing the guy's face, like back behind his ramus of his mandible, you're probably not doing that. This is a really hard thing to do. Really hard to do, especially with one hand. And I will definitely argue that, yeah, you may be able to do it for a short period of time, but for the most part, you are smushing the mask onto the guy's face and not lifting his jaw up if you are using a one-handed grip. So the first thing you should probably learn is you can't hold a one-handed mask seal. Stop trying to do so. Now, I do not claim originality on this, maybe a little bit, but I think I was at a conference where Jeff Jarvis, who is a medical director from Texas and kind of talks about airway stuff, said this exact same thing. And I thought, you know what, that is perfect. That's what I've been trying to say for so long. I took it, and at the time, I sort of paid Twitter a little bit of mind, and so I put it up on Twitter and credited Jeff Jarvis at it. And immediately, everybody locks on it. I can hold a mask seal, blah, blah, blah. Literally, people from Australia and from Europe were putting in their things and saying, like, oh, look at what the Americans are sending us, blah, blah, blah. And the Australians are saying, hey, Bruce, you see these guys saying we can't hold these mask seals, and look at these wankers. Which brings up my second point. You shouldn't be using Twitter. Twitter sucks. But that is, everybody thinks that they can hold a mask seal for any given length of time. And maybe if you are an exceptional Australian anesthesiologist with exceptionally large hands and forearm strength, you can do it. But nobody else can. I can't, not for any length of time. And I've got a pretty, good-sized meaty paw with a decent amount of strength in my fingers, and I've done this a bunch. And I say you can't do it. So I'm going to postulate and say that probably we shouldn't be doing it at all. Maybe you're super at it. Cool. Just do it my way anyway, and we'll all be happier, eh? But here's another example of it. You can't grab these obese people's faces with one hand. It's just not going to work. There's too much like flubby stuff. There's too much spittle and stuff, especially in the emergent places. If you're an anesthesiologist and the patient is shaved and they are dry and you have all your stuff in front of you and you don't have to squeeze a bag or worry about that the patient a minute ago was holding a gun, maybe that works. For what we're doing, you can't do a one-handed mask seal effectively for any length of time. Maybe for a breath, maybe for 2 breaths, but then you're going to lose that seal. So don't do it. Use a 2-handed seal, which is going to require somebody to, one person to grab and then one person to squeeze the bag. And you should absolutely do that. And when you do that 2-handed mask seal, here we're getting back to the jaw thrust, you need to do an actual jaw thrust with it, not just we're holding it on his face, but we are lifting the jaw up each time. Here is a fluorograph of what happens when you move a patient's jaw around. So there's the head tilt, and you notice there's the patient's airway at that point. That was, okay, we did the head tilt, which is pretty much all that most patients get, quite honestly. The green highlights the airway space itself. Now, here's the head tilt plus a chin lift. There's the chin lift. And okay, he's got some more space, a little more space down in his lower airway, but you notice there's nothing up in his, there is no space up here. You have blocked off the top of it because his tongue is now flopping off there. And okay, I got a little bit more space down here, but that's not really going to do a whole lot of good when nothing can get past his big floppy tongue that's occluding his airway. Here is a jaw thrust itself. He's going to grab, lift, and you see all that beautiful, nice patent airway open. You could drive a Mack truck down there, let alone bag through it. But you can only do that if you actually get jaw thrust. Back behind the angle of the jaw and lift up, which I can't do on myself. But that's why you need to do a jaw thrust. Again, with feeling, somebody else is probably going to have to squeeze the bag because you are going to have to actually grab and do the actual thrust. I had a resident the other day, we were dealing with a critical airway. God love him, he was really trying. I said, sir, do some jaw thrust there for us, would you, whilst we're getting the rest of this out here. And there was a little bit of like, kind of touching the jaw. It is not a touch the jaw, it is a grab and lift the jaw up. And you should physically see the patient's head move, or at least their jaw and all this move with it. One more time with feeling, you need to do it to bag. You need to be able to see the patient's jaw move with it. It's not just like, this shouldn't be a subtle thing. So hopefully I've convinced you about why you should do this while you are bagging, and it is going to make your seal better. It's going to make air go in better. It's going to reduce the amount of pressure you have to use and the amount of air that you entrain down into the esophagus. Let me throw something else at you. Consider doing this while you're intubating. I almost guarantee you are not doing this while you're intubating these folks. And that's probably a little bit of a shame. But for the most part, we're bagging. Even if we've got 2 hands on there, you're probably like bagging. And then when you go to intubate, the guy doing the jaw thrust just hands off, okay, off we go. Consider keeping that jaw thrust in place. Why? Because the whole idea of laryngoscopy is to get in there and like lift the jaw up. If you can already lift the jaw up to whatever extent you need to, it's going to make your motion with the laryngoscope that much easier. So consider the jaw thrust while you are actually attempting to intubate, not just beforehand. Here is an example. You'll see this. They've got a fibroscope down the patient's nose, and you'll notice what happens when they lift the jaw up. It's down here. I think this plays again, hopefully. Yeah. Just lifting the jaw up gives you so much of a better view. Now, you can do some other stuff with it, but just doing the jaw thrust itself whilst you are intubating may make the actual intubation process phenomenally easier to do. So when, instead of your buddy who is doing a great 2-handed seal, instead of him bugging out when you pull the bag off and get in there with the laryngoscope, have him keep doing that jaw thrust and see if that doesn't actually make it a bunch easier to intubate already through a patent airway with quite a bit less force applied on the laryngoscope itself. I would like to bring up just one more thing about this beautiful video here. When you look at this cat, one thing that you do not notice, at least initially, is that, is that his head is not laying on the bed. His head is on a pillow. His head is extended and translated forward. Again, extended and translated forward. It's not hyperextended. It's not dangling off the back of the bed. It is lifted up and moved forward. This guy is in the optimal sniffing position, and if you aren't putting folks in the sniffing position when you attempt to intubate them, even if they're in cardiac arrest, if you are not elevating their head so that their ear is level with their sternal notch and all that is level with the floor, then you are making it harder on yourself. So when you go to intubate somebody, put the head in the sniffing position, in the actual sniffing position. It's not hyperextended. It is extended, more or less neutral, just a little bit extended, but then translate the head forward. Looks something like this. They talk about ear to sternal notch. That's true. That's what you want. You mostly want the plane of the face up here sort of parallel with the kind of the plane of the chest to make that really happen. But yes, you want the ear lifted up to the sternal notch as much as possible. It doesn't look like it because pictures aren't very good at showing actual airway anatomy, like functionally once you get in there. But that actually, again, opens up your airway and makes a much cleaner, less snaky path to get down into the trachea itself. Here it is on another person. Again, this you'll notice that the head is lifted up on a set of towels. It's extended but not hyperextended. And their face is more or less parallel with the line of their chest, essentially with their trachea, for the most part. Now, it's not this. This is, we've got towels, and we put towel roll under the patient's shoulder. They're in the sniffing position because they sniff like this. That's not it. Even though it doesn't look like it, you think, okay, that's going to make the whole thing, their mouth is now lined up with their trachea. This is going to make it much easier. It's not going to make it much easier. It's going to make it quite a bit harder because you've still got to snake down from their mouth through all their upper airway, and then you got to get back up to their trachea here. Put them in the sniffing position, and that won't happen. By the way, why does the sniffing position make such a big deal? Well, I know you probably have, if you're an EMS provider, have not seen a whole lot of CT scans, but this is a CT scan through the bottom of a patient's neck / upper parts of the patient's chest. And this is an obese person, by all means. This is the front of the patient is up here, back of the patient is back here. Their trachea is right here, and you see that it's surrounded by a mass, a protective layer of muscle, and when you get out there, fat. And we all have this to some extent. Even if you're not super obese, even if you're relatively skinny, you have muscles and stuff that keeps your shoulders and your back up, lifted off the bed. So if this is the trachea in here, what that means is that this person is laying on a cushion, a towel roll of flub, kind of on their back, which causes their head to dangle when you lay them flat on a bed because the back of it is being propped up by all this soft tissue that's in the back of them there. Soft tissue, muscle, and all that kind of stuff. And so you have to lift the patient's head so that they're no longer dangling. And again, this doesn't have to be a super obese person for it to happen. We all have some degree of soft tissue and stuff back there that causes our head to dangle off the back of our body when you lay flat. It's worth noting, too, that the sniffing position is not this. It's not the head hyperextended, because when you hyperextend the head, you actually make things a lot harder to get to, too. And it's not this. It's not dangling the patient's head off the back of the bed. I saw this show up, and every time I see this, I think, oh, my God, why are people so gullible? This is not, they're like, oh, look, ear is to sternal notch. See, here's the ear, here's the sternal notch. It must work. Well, no, this patient's head is dangling off the back of the bed. That's what they're doing. If you turn the picture 90 degrees, if you look at the plane of their face, their plane of their face is right here. It is not 90 degrees, but probably at least 45 degrees to the angle of the patient's chest, or where their trachea actually is. If you turn your perspective, that's what the patient is doing. They're dangling their head off the back of the bed, which is not an optimal intubating position at all. It's going to make things a lot worse. So don't think that even though, okay, I've lifted his head up, well, you've only changed your plane of reference. You haven't actually done anything to make the patient's airway less curvy. You've only made it a little bit harder on yourself in doing so. And by the way, well, ear to sternal notch, that's what you're saying. I can draw a line from this patient's ear to their sternal notch in any position. Again, just by changing my frame of reference. Ear to sternal notch is not the thing. Yes, the ear should be at the level of the sternal notch, but everything else has to be planed out parallel as well. So just because you can draw a line between 2 points doesn't mean you've actually done anything good for the patient. Same thing here. I will say it one more time. Just rocking the patient's head back, even though they're slanted upwards, does not make it, not mean that they're in a good position. It looks something like this for most folks. It does involve you sort of lifting up the back of the patient, because you can't just like take their head and smush it forward. It means you got to kind of ramp up most of the more obese patients so that they don't kind of fall while they're not hanging by their head essentially. And in practicality, it looks something like this. Even the model for this particular picture is relatively thin, and she doesn't have a lot of like adipose tissue back here. But she, in order to get her ear to sternal notch, she still has to have her head elevated by, was that 4 towels or something like that? It's relatively a lot. So don't forget that even thin people may need this in order to get in the optimum intubating position. When you start doing this, the benefit of it, how much easier your intubations will become, is going to be remarkable. And it is literally one of those things you will say, oh my God, why has this been kept from me all my life? It will make things so much easier for you. And that's coming from somebody who never did it, and then when I started doing it, absolutely, it's a life changer. So start doing it. Point, I think we're on number 3. If you're going to intubate somebody, this is a lesson that I've learned. Put a nasal cannula on them, and then keep it on. We often think, let's say you're doing some sweet BVM action in preparation for intubating. What are the things that you need? Because we want to get this guy pre-oxygenated so that we have lots of time to get in there and make mistakes and try new things. What do we need to do to safely get this guy pre-oxygenated with a BVM? Number 1, we need an airway adjunct, which he has. He has an oral pharyngeal airway. That's good. Step 2, you need to have a good 2-handed seal on that bag with a good jaw thrust. All right, that can be excellently done. Number 3, you need a PEEP valve on that BVM. And you may say, well, what does that have to do with the nasal cannula? I'll get to it in just 1 second. First, I do want to say you still can't hold a one-handed mask seal for any length of time, so you should stop trying to do it. Put 2 hands on it. It's going to take 2 people to bag this patient. But back to that PEEP valve on this cat. Why does a nasal cannula make a PEEP valve work so much better? Because he will pre-oxygenate so much better, or oxygenate if you're just using a BVM. He will oxygenate so much better if you have a nasal cannula on this guy. The reason is when you look at PEEP, positive end expiratory pressure, we've seen it, we've heard it, we love it. Here is a set of lungs of some creature without PEEP, and then you put PEEP on it. And what does PEEP do? It maintains just a little bit of pressure inside the lungs, doesn't let them completely exhale in order to keep the alveoli open. Because if they smush down, they're like a plastic, shopping bag that got wet. You know how it all sticks together, and then you gotta like blow in it and try to blow it back up. That injures your alveoli when they have to do that. And so if you keep the alveoli open with PEEP, then you don't have to open each one individually when you blow back in there. So PEEP is helpful for your lungs. Here's the problem with the mechanical PEEP valve on a BVM, though, and it'll go right there. The problem is that this is a spring-loaded valve that sits on the exhalation port, and it leaves, if you set it to 5 centimeters of water pressure, then it leaves 5 centimeters of water pressure in there. And that's cool as long as you have a perfect seal on the face, and the patient's lungs and body and their upper airway and everything behind the PEEP valve don't change in size. Because the minute you change in size, the minute they relax a little bit more or something, you get just a little bit of leak, that PEEP entirely goes away. So it does work to maintain some PEEP. Not a lot of effective PEEP, though, unless you have an absolutely perfect closed system that doesn't move after you give the breath. There's a way to fix that, though. And that is to put the nasal cannula on the person. So consider this setup here. You have the BVM on flush rate, 25 liters per minute. You have a nasal cannula on the person. You turn it up to flush as well, 15, 20, as high as the regulator goes, basically. It's going to require 2 sources of oxygen, by the way. Maybe easiest to do in the back of the ambulance rather than on a portable tank. Just as an FYI. You're going to be using a lot of oxygen, but these folks need it. And then you stick a PEEP valve on the exhalation port of the bag. What does this give you? First of all, the patient could breathe through this. This is the poor man's CPAP that we've described previously. You have a constant source of oxygen up here. They're able to breathe tidally through that valve, and then they have a constant source of oxygen here to maintain PEEP. So this is the poor man's CPAP if the patient doesn't have it already. What does this do if we're actively bagging the patient, though? What it does is it means that if you get a little bit of leakage of gas around the seal of the mask itself, or if their lungs change in size a little bit because they distend a little bit or something like that, or you get a little bit of air entraining down into the esophagus or something like that, the nasal cannula on high, basically on, fills up the mask, and it will fill it up to the pressure that you set at the PEEP valve, and then the PEEP valve will let extra air out. So you actually maintain that PEEP, even though you may not have a perfect mask seal. You more or less maintain it. You'll maintain it a lot more effectively. Or again, if their chest changes ever so slightly in size, you will maintain that PEEP despite all the dynamic factors that can kind of occur in the meantime. Now, yeah, that does burn up a lot of oxygen, but for these folks that actually need it, it makes a big difference. Here's a little more of an example. I'll skip over some of what I was going to talk about with it, but basically, this is a cadaver, and so let's just jump to the next one here. What they've done here is put the nasal cannula on. It's on high, basically. It's high as the regulator will go. And they've got a PEEP valve on this BVM, and he's not even going to squeeze it, but what you will eventually notice, he is squeezing it in this one, sorry, I jumped ahead, is that when he squeezes and then lets go, that the lung stays at least somewhat aerated. It stays open and pink. You've done effective PEEP at that point, whereas if he was just squeezing it with the nasal cannula not on there, you'd get some of that, but not a lot. Now, criticism, he's not using a two-handed seal, but okay, whatever. Here's another thought, though. Hopefully I've convinced you to keep the nasal cannula on him whilst you are doing the BVM, because it will be helpful. Why not leave the nasal cannula on after that, though? Just leave it on and let the person keep getting that apneic oxygenation with it. That way you don't have to put it on right before you try to intubate the person. What's apneic oxygenation? Basically, put the nasal cannula on the patient. We're going to actively try to intubate him. This works best if the patient's heavily sedated, if not paralyzed, but mostly not breathing. It's okay if they're breathing, like that's fine. If they take a breath in the middle of it, it's just oxygen. But even if the patient's not breathing, what this allows you to do is to instill some oxygen into the lungs. It's not that the pressure is so high up in their face. It's that when you break when you break it all down there, you've got oxygen that goes from your trachea down through your airway into your alveoli, down into the lungs. And then the oxygen eventually, through magic, gets transferred into your pulmonary vasculature, and then it gets taken out to the rest of the body, and that's how oxygen gets in your lungs. When it gets pulled out of the alveoli, though, that leaves, if you want to think about it, a little bit of a dead space there. Not a dead space, but an oxygen vacuum. And if you have a high concentration of oxygen up here, oxygen will be drawn down through the airway into the alveoli, just based on that the blood's picking it up and running away with it, and the body, or that nature is trying to fill that vacuum, in this case with the extra oxygen that you're supplying via the nasal cannula. Interesting how long you can keep somebody with a SAT above 95% when they are completely apneic with this. Let's see, this line here, this is the if you are not using nasal cannula, if you're not using the apneic oxygenation, versus this one, these guys get out to 300 seconds, complete apnea time. Their SAT's still above 95%. They never get hypoxic. These guys, you get 80% around here, 50% around here. What is that, 120 seconds, thereabouts? So you may have a minute of apneic time without the nasal cannula, and you have, upwards of 300 seconds, which, I don't know, do math, 5 minutes or more of safe apneic time if you use the nasal cannula. And again, this, you can criticize the study for what it's worth, but that's what it says, is that you have more time if you're using the nasal cannula on and flushing oxygen down their nose than if you don't. And that's good for most of us, because most of us need a little bit more than a minute to actually get somebody intubated. And there's nothing to say that this couldn't work in like your cardiac arrest patient or your patient that's not spontaneously ventilating, that you're not using paralytics on or something like that too. So you should probably be intubating with a nasal cannula on the patient. Pre-oxygenate them with a nasal cannula on the patient. Even if you're using a BVM, keep the nasal cannula on whilst you're intubating as well. One other thing real quick, I brought this up to somebody the other day. This is a relatively quick one. They were using, in this case, a video scope. They had a blade in the mouth and just couldn't get the ET tube to go where they wanted it. And the patient had a little bit of a small mouth, but I just kind of brought up like, here, let me do this. I grabbed the patient's jaw, I grabbed the patient's cheek, and went like this and just kind of held it down. And they're like, oh my God, what'd you just do? Well, I grabbed the patient's cheek. Using like the little fish hook technique or the side door technique to get into the patient's airway is something that I think we kind of forget about sometimes, but it can be really useful. And I'll tie it in with the rest here. This is a guy that, you know, relatively small mouth. They have a good view. You can see, you know, you see it. There's cords right there. Yeah, you should be able to hit that, right? Sure. Great view. And come on, get the tube. Well, long story short, he's going to mess it up. He is going to fail to get the intubation because he's unable to deliver the tube down through the patient's little tiny mouth. He loses visualization. He can't quite get it bent the way that he wants to. He's not going to get it, even though he's got a great view of the cords themselves. If he were to grab, or who were to grab, or somebody else grab the side of the patient's mouth, you'll notice that you get a lot more space in there, and that space can be a big deal. Think of it sort of this way. You know, here's the way we sort of think of intubating, but the tube delivery itself, if they have a little mouth, sometimes means you just can't get it anterior enough. If you grab the jaw and free up a lot of space over there, then there's nothing to say that you necessarily even have to go down the midline anymore. You could come in off to the side and sort of go parallel to the floor almost. If you think about it, here's where the patient's lip normally is, sitting up here, meaning that you have to go down through the patient's mouth. If you can grab their face and pull their lip down to like here, then you're almost at the level of the cords to start off with. And in some people, if you got a big mouth, like you can really pull that over there. If you think about it, if you have enough time there. And this is me doing it to ignore the grip. The grip was done to facilitate taking the picture so that my hand wasn't occluding it there. But just grab the patient's jaw and pull it over. And who should do that? Well, intubating is a two-person sport. I would say that whoever is maintaining that jaw thrust while you're attempting this, that's what I'm kind of doing there. I'm sneaking my thumb up, grabbing the patient's side of their mouth, and pulling that off to the side to do that little fish hook thing. Because my hands are already there. I've got my hands on the patient's thing. There's an operator up here who is intubating. I'm just holding the jaw thrust up there, and if I just sneak my thumb up there, I can give him that little fish hook. I can give him, 2 more centimeters of space, which can be the difference between life and death in these intubations. So do consider this another reason to have somebody else's hands on the patient's face. You do probably have more space than you thought that you had previously. I'm almost out of time, but I've only got 4 slides left, so I'm going to barrel on through it. Let's just say that if you are intubating, you can use more than one hand for more than one thing. What do I mean? Well, let's face it. I got hung up there. What do I mean? Well, when you're intubating, most of us kind of think like, all right, I intubate, I'm using my left hand. I'm laryngoscopizing, I'm doing laryngoscopy, I'll get it out there, with my left hand. And so my left hand is the thing that I need to, keep skilled in this. And we kind of forget that we have this whole other hand here that is free to do other stuff. Usually it's like sitting on the table, or it may be like holding a suction tube, or it may be holding on to an ET tube or something like that. You can use your right hand when you are using your left hand. You can use your right hand to do other stuff to improve your view. Now, that's what these guys are doing. What this person is doing with their right hand is they have their fingers on the patient's larynx, and they're using the laryngoscope to lift up the tongue and pull the jaw out of the way and that kind of stuff. And then they're going to use their right hand to push in this case, like kind of back up, maybe a little bit of rightwards pressure, the burp type stuff. They're doing that with their own hand. What that allows them to do is get the patient's vocal cords into a good spot. Here's a good examples of this from Taryn Trott's 5-minute Airway. I wish he would do more of these because they were actually, I loved them when they're out there. You'll see, there he goes. You could see the view that you got ahead of time, and then the reason that's moving around is because the operator has their hand on the trachea, on the thyroid cartilage there, and is manipulating it around. He's going to do the same thing here. You see the view that you got ahead of time, and there he is. He's literally moving the thing so that he can see it better. There it goes. And you can often take what would be a marginal view at best, or sometimes even a really bad view, and you can take an it's extralaryngeal manipulation. So you can extralaryngeally manipulate somebody into a almost grade 1 view, almost a perfect view, and facilitate intubation just by using your right hand. Now you may say, like, well, okay, that's all well and good, Walt, but what you just said was I took my right hand and I put it on the patient's neck, and I've got the laryngoscope in my left hand, so how do I get the tube in there? This is where your partner comes back in, and he may have to let go of the jaw for this to work. But what these guys are doing, laryngoscope in the left hand, they take their partner's hand, set it on the patient's neck, and then they put their hand over top of it, and then they're going to wiggle their partner's hand, which wiggles the trachea, wiggles the glottis, does your extralaryngeal manipulation. He's going to move that around until he gets it in the spot he wants, and then he's going to say to his friend, hey, hold your hand right where it's at right now. This takes a little bit of doing, a little bit of coordination. It's sometimes hard for the person to kind of loosen up their hand and let you move it someplace. But with practice, you may be able to do this. A lot of times you can also kind of direct the person, say, okay, give me some backwards, upwards, rightwards pressure burp. So backwards, upwards, a little bit to the right. Do that. A lot of times you can kind of get somebody started there, and then you could take your hand up and kind of fine-tune it from there. It's like, yes, that's perfect. And then come in with the tube on the with the other hand after you get it out there. Last thing I'll pull up, or I'll make the point of, is just to say, whatever you're going to do, get good with your thing. Neither you nor I are realistically going to get enough intubations to like really spread it around and get good with a whole bunch of different tools, which is a little bit unfortunate. You know, I probably have done more intubations than most pre-hospital providers, I'm pretty sure, just because that's part of like your training. You're supposed to do that when you do a residency. How many intubations have you actually done? For most of us, for paramedics especially, it's going to be, well, I did 10 in school because that's what I had to do, and then most paramedics get like maybe 1 intubation a year. Let's say 1 intubation a year, maybe 1 every 2 years, something like that. So over the course of a, let's say, 30-year career, you do 40 intubations. That's not enough to get good with a number of different things. Now you can practice a bunch of different things, but I will tell you that what I would recommend is that you get really good with one kind of setup. Don't switch around constantly. If you like video, do video. If you like direct, do direct, whatever. I think video really is the better choice for most of us who are not intubating people literally on an everyday basis like anesthesia is. I think video laryngoscopy is a really good thing for most folks, and I use it pretty frequently. I can't even remember the last time I used a scope, or I used a laryngoscope that didn't have a camera on it. But get good with your setup. Be able to manipulate your setup into doing all the stuff that you need to do. if you try it a different way each time, you only get like 30 chances at this in your entire life. Again, if you're the typical paramedic in the United States, you don't get that many chances to practice with this. So you can do some training stuff, but when you actually get out there and do your live thing, make it sure that it's the thing that you have actually done before. Otherwise, if it's a one-off, it's just a one-off, and you're not going to get very good at it. But I would recommend practicing intensively with your setup and make that your thing, and then do it your way each time so that you stay good at it, because it may be your mom that's getting intubated next time, or your wife, or your kid. So I want you to be good with your thing, and I don't care which device you use, but do get good with your thing. So that's actually 6 airway points instead of just 5. To sum up, you can't hold a mass seal with one hand. Please stop trying. I've said it again. Twitter's mad at me. Twitter still sucks. Sorry, did I say that? Okay. When you're going to position somebody for intubation, or for bagging for that matter, put their face to the ceiling, extend their head, and translate the head forward. Don't dangle their head off the bed. Don't dangle their head off the top of the bed. When you BVM, it should be with 3 hands, and you probably need 4 hands to intubate effectively, especially in an emergency setting where all these are difficult airways. If you are going to BVM somebody, consider putting on a nasal cannula, and if you're going to intubate, hopefully they already have the nasal cannula in place. So, that's what I've got for today. I appreciate your attention and your time, and your putting up with everything that I've got to talk about.